Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show.
I'm John Strum, and this is Real Talk MS. It's April 17th, and this past week has been a busy one. I started last week in Sacramento, California, participating in the National MS Society's State Action Day, and I had the opportunity to visit about a half dozen state assembly and Senate offices to talk about how important it is to have access to quality, affordable health care, why it's smart to provide full disability access in public restrooms, and why we need to ensure that people living with MS have access to affordable prescription medications. I especially appreciated the opportunity to meet with California Assembly Speaker Anthony Rendon, who was not only gracious with his time, but extremely supportive of the issues that are important to families living with MS. I ended my week in Houston, Texas, where I was invited to meet with a group of MS Society supporters and give them an update on the work of the International Progressive MS Alliance. Because I have the honor of being the only American lay member of the Progressive MS Alliance's Scientific Steering Committee, it makes me very happy whenever I have the opportunity to share news about the Alliance and the global research projects that it's actively steering, the global progressive MS research agenda that it continues to influence and drive forward, and the incredibly high level of commitment on the part of every member of the Scientific Steering Committee that continues to amaze me. And I want to especially thank Katie Donovan and Shannon Nelson of the MS Society for making sure that every aspect of my visit to Houston was just about perfect. You know, when we think about MS, we tend to think about it as an adult disease. But the National MS Society reminds us that between 8,000 and 10,000 children up to 18 years old are living with MS in the United States, and studies suggest that between 2 and 5% of everyone living with MS has a history of experiencing the onset of at least one MS symptom before the age of 18. When I think about how challenging living with MS can be, I can't even imagine what it must be like for children and adolescents who have to deal with all of the uncertainty of MS while they're also dealing with all the trials and tribulations of just growing up. And those can be challenging enough for kids who are completely healthy. Today, my guest on the podcast is Dr. Emmanuelle Waubant, one of the true pioneers and experts in the field of pediatric MS. We're going to talk with Dr. Waubant about some of the differences or challenges involved in diagnosing pediatric MS, which treatments are used for pediatric MS, since the FDA hasn't specifically approved any drug to treat pediatric MS, and how kids living with multiple sclerosis deal with all of the challenges that life throws at them. But first, there are a few other things that you should know about. The Healthcare Cost Institute, an independent, nonpartisan, research-driven think tank, issued a report last week that shows spending on healthcare for people living with multiple sclerosis nearly doubled between the years 2009 and 2015, rising from $23,900 to $39,600 per person. And the primary driver behind this increase was spending on disease-modifying therapies, the medications designed to help manage MS. The report went on to recognize something that people living with MS are all too familiar with, that even as new treatments became available, which created more competition in the prescription drug marketplace, the price for all disease-modifying therapies for MS continued to rise, Now, if you recall what you might have learned in an introductory economics class, in a free market, increased competition always drives prices down. But for some reason, this has never been the case when it comes to MS prescription medications. Today, the cost of healthcare for MS patients in the United States is estimated at $10 billion a year. And this past year, members of the U.S. House of Representatives Committee on Oversight and Government Reform launched an investigation to determine the cause of these nearly constant increases in the price of disease-modifying therapies, including requesting price strategy information from 7 different drug makers. If you're taking prescription medication to help manage your MS, I know that none of this is news to you. While the Healthcare Cost Institute's latest report only covers the years between 2009 and 2015, you can rest assured that since 2015, costs for these disease-modifying therapies have only continued to go up. And that's just one more very important reason why it's vital to advocate for transparency when it comes to prescription drug prices. No one wants the pharmaceutical companies to lose money. No one wants these companies to stop innovating and bringing new and improved treatments to the people who need them. But when we see the price of prescription drugs defy all normal laws of economics and continue to rise exponentially, we need to, at the very least, be able to understand how and why that happens. So we'll continue to talk about this issue. We'll continue to remind our legislators that these medications can be life-changing for hundreds of thousands of people with MS across the United States. And we'll continue to advocate for greater transparency when it comes to the price that we pay for MS medications. In previous podcast episodes, we've talked about how your smartphone will become increasingly important as a tool to help manage your MS. And there's news about one more way that's likely going to happen. The United States and Australia have each issued patents on Sond Health's voice analysis technology for diagnosing and monitoring multiple sclerosis and other diseases that can have an impact on your speech. Sond's vocal biomarker technology extracts specific acoustic features from portions of a person's speech, and by analyzing these vocal features, the technology has a potential to diagnose or track MS, Alzheimer's disease, Parkinson's disease, and even major depression disorder. This technology has already been tested and evaluated in more than 3,000 people. It uses a person's smartphone, so there's no special equipment required. There's no need to make an appointment and get to a doctor's office or any other healthcare facility. And by diagnosing and monitoring diseases with devices that most people already own, this technology can be a game changer in the way that our physical and mental health is diagnosed, monitored, and managed. Dartmouth Hitchcock Health System, which is affiliated with Dartmouth University Medical Center, is launching a 3-year multi-center study of the quality of care that multiple sclerosis patients receive. This is the very first collaborative study in the United States that will focus on quality improvement in MS care. Now, in the first year of the study, researchers will gather information about the current status of MS care. The following 2 years, they'll follow study participants through a series of quality improvement initiatives. Beyond evaluating disease-modifying therapies for MS and using MRI to track the disease, investigators will also evaluate patient outcomes, including relapse rate and quality of life. The study is being conducted in collaboration with pharmaceutical manufacturer Biogen, Massachusetts General Hospital's Multiple Sclerosis Center in Boston, and the Concord Hospital Multiple Sclerosis Specialty Care Program in Concord, New Hampshire. 4 more sites are expected to join the study this year, doubling its scope to focus on more than 10,000 patients living with MS. If you're living with MS, then I'm sure you remember when your diagnosis was confirmed by an MRI exam. The man who pioneered the use of magnetic resonance imaging to improve diagnosing and understanding multiple sclerosis is Professor Frederick Barkoff. And Professor Barkoff will be honored next week by the National MS Society and the American Academy of Neurology as this year's recipient of the Distal Prize for Multiple Sclerosis Research. Professor Barkoff's contributions include the development of MRI criteria for diagnosing multiple sclerosis. His team defined the guidelines to focus on specific brain regions to look for MS-related lesions, which are known now as the Barkoff criteria. These guidelines have led to more reliable diagnosis, and they're the basis of today's MS diagnosis strategy. Professor Barkoff is a professor of neuroradiology at VU University Medical Center in Amsterdam and at University College London in London. He's authored 3 books, written more than 900 peer-reviewed articles, and was named one of the 3,000 most influential scientists in the world by Thomson Reuters. Professor Barkoff will receive the 2018 Distal Prize and be honored at the upcoming annual meeting of the American Academy of Neurology, where he'll also deliver a lecture. I'll be at the annual meeting of the American Academy of Neurology, and I'm hoping that we get a chance to speak with Professor Barkoff on the podcast. And speaking of experts, in a moment, we'll meet my guest, Dr. Emmanuelle Waubant, one of the leading pediatric MS experts in the world. Dr. Emmanuelle Waubant is recognized as a leader in pediatric MS research and practice. With the support of the National MS Society, Dr. Waubant started a regional pediatric MS clinic at the University of California, San Francisco in 2006. She's the editor of the very first textbook on pediatric MS and related disorders, and Dr. Waubant is also an at-large board director and a member of the program committee of the American Committee on Treatment and Research in MS, or ACTRIMS, and the chair of the U.S. Pediatric MS Steering Committee. She also chairs the International Clinical Trial Task Force for Pediatric MS, and Dr. Waubant also serves as the Race to Erase MS medical director and coordinates clinical research collaborations between 6 American MS Centers of Excellence. Welcome to the podcast, Dr. Waubant.
Thank you. It's a pleasure to be on your podcast.
Well, you know, my wife was diagnosed with MS back in 1997, and then I really don't remember hearing or reading much about pediatric MS. So I'm wondering, has something changed over the past 20 years that now allows neurologists to more precisely diagnose MS in children?
So back in '97, actually, there were already some cases. And actually, when I was a fellow at UCSF MS clinic, then I started to see a few pediatric patients, in large part because some of my colleagues, or I should even say all my other colleagues, were not comfortable seeing these patients because they took more time and they didn't feel comfortable with children. But at the same time, I felt that it was important to be able to offer our expertise to these young patients. And so I had started to see some pediatric patients back then, but you're correct in that there was not much attention towards pediatric MS because he was under-recognized. I think that it's really the effort of the National MS Society that was started in 2006 that put pediatric MS on the map because it has allowed for the development of multidisciplinary clinics in different parts of the U.S., and that has enabled also researchers involved in these clinics and people collaborating with these clinics to actually start having a better understanding of pediatric MS in general. So I think that now that we know more about it, we can recognize it better and earlier. When you took the database from a large MS clinic, you would realize that there was probably at least 5% of the patients who were adult MS patients who actually had an onset in childhood. And a substantial number of these patients actually were not diagnosed until they were young adults, in part because the physicians who would see pediatric MS patients early on would be either pediatricians or child neurologists, and there was not much known about pediatric MS for these specialists. There was more known about acute disseminated encephalomyelitis, also called ADEM, which is a disease that can mimic actually MS when it has its, because the onset is very similar to MS onset in some cases, and very often these cases were diagnosed as ADEM when they were actually the first event of MS. And so I think that there's more understanding now that actually pediatric MS is probably about as frequent as ADEM. But both are rare. So there was a study that looked at the incidence in Southern California that suggested that there was an incidence of about 1 per 100,000 children per year. So not super frequent, but at the same time not as rare as one could think.
Is MS in children, does it present differently than MS in adults?
So for teenagers, the presentation is more or less the same than in adults. Teenagers, like starting around 12 or 13 older, they are fairly similar to adults. For the younger patients, so 11 and younger, there are some differences. Also, I would say that for the very young patients, or patients like 4 or 5-year-old, then there's even a little more differences, and the differential diagnoses are a little different. So, for example, ADEM is more often seen in young patients, so patients like 5 and younger. But it's usually not seen so much in teenagers and very, very rarely seen in adults. And so I will take an example. Very often young patients, so patients around 4 or 5, if they have the first symptoms of MS, they may have a presentation that is more in line with what we think could be ADEM. So they have changes in their behavior, they have some lethargy, sometimes, being very sleepy, and in addition to deficits such as decreased vision or double vision or weakness. Sometimes they can also have headaches if they have actually a lot of MS scars that are active at the time they present. It's actually very infrequent to see headaches related to MS flares in adults, but in the young children, it's not uncommon. And we've diagnosed a few times patients who had severe headaches, who were 10 and younger, who were at the end referred for a brain MRI because their pediatrician was starting to be concerned, and they were actually changes on the MRI very suggestive of active MS. So there are differences in the presentation. There's also differences in the severity. I would say very often children tend to have maybe a little more severe exacerbations, but then they recover better than adults. So that would be another set of differences.
That makes me wonder, are children living with MS, are they all living with the relapsing remitting form of MS, or are some of them being diagnosed with progressive MS?
So that's a very good question. We think that there's basically no primary progressive forms of MS. We have seen a handful, and when I say we as a network in the U.S., we've seen a handful of patients with secondary progressive MS, but usually it's not a first diagnosis we would have. And when we see a patient in who we see a progressive onset of symptoms, we really work very hard to rule out other disease, so mitochondrial disease, genetic disorders, or other disease that could result in progressive course, because it's really very, very rare.
I know that obviously adults who are living with relapsing remitting MS have about 15 different disease-modifying therapies that they can try and with their neurologist hopefully fine-tune something that will work for them. Is there a specific treatment protocol for pediatric MS? Have any of the approved MS drugs been approved specifically for pediatric patients?
So until this year, and actually it's not even done, but this year is going to be, we anticipate that the first adult drug will be approved for pediatric MS in 2018. But until then, there was basically no drug approved for pediatric MS. So what happened is that physicians progressively try to use all the adult drugs or most of the adult drugs for young patients. Sometimes health insurances would deny some, but not too commonly. I mean, that happened more often back in the 90s, I'd say, when some of the drugs on the market then, which was basically a couple of interferon and glatiramer acetate, were actually glatiramer acetate were on the market, and occasionally health insurance would deny use in children because they said, well, it's only approved 18 and above. And so that's when actually there were efforts to try to actually collect information about children who had been treated with those medications. So as I was a fellow, that was one of my research projects, was to contact neurologists and child neurologists all over the country to try to identify practices where some pediatric MS patients had been seen and were treated with some of these medications. So we put together the first paper on the safety of interferon in pediatric MS, and then there was a second paper coming from France that did the same thing than we did. And from there on, there was very, very seldomly denial for use of the treatment. However, the health insurance is an issue, but then the level of comfort using the medication per physician standpoint is different. So for the teenagers, the doses are not different from adults, but there's a concern for some of the drugs that maybe in the long term they could induce issues with growth or safety, secondary cancers, or immunosuppression, or increased risk of infections. Whereas for the young patients, so patients who are usually under 10 or patients who are less than 40 kilograms of weight, then for some of the drugs, there's really strong consideration of how do we have to adjust the dose. For interferon, doses have not been adjusted, so we continue to ramp up over 1 month, and we use basically ultimately the dose that is used in adults. For glatiramer acetate, the same, but for the other medication like natalizumab would be one for which we're using some information from the phase 2 trial in adults to try to tailor the dose for young children according to their weight. For the other medications, so some of the oral agents that have been approved in the past 5 to 6 years, there's actually no recommendation of dose change because it's not being tested in children. However, there are clinical trials that were either just completed or are ongoing in pediatric MS that will help answer those questions.
Aside from the dealing with the physical symptoms and aspects of multiple sclerosis, it seems as if pediatric MS presents a set of psychological and social challenges to the patient that adults with MS don't necessarily face, or at least they don't face these particular challenges in the same way. You know, for instance, a child or a young adolescent is still filling in a lot of the blanks when it comes to understanding who they are. They're experimenting and trying to understand brand new social situations, and they're going to school every day, which carries with it a whole set of social challenges that they're just learning to navigate. How does their MS diagnosis impact those kinds of experiences, which are extremely challenging for children and adolescents who don't have MS?
Yes, this is exactly the challenge we face with pediatric or childhood MS. So I think it's especially difficult in teenagers because they are really, becoming independent. And so teenage is already a rocky time in their life because, they want to be able to be with their peers, recognized by their peers, and really develop their own personality and way of life. So it is a difficult time, but also, it in part depends also on how the parents embrace the diagnosis or not. I think that if the parents are reassuring and they are not over-coveting teenagers, I think things are usually better. Occasionally, parents are being extremely scared, and we understand why that happens. But at the same time, when that happens, they convey some kind of anxiety to the children. So it's very interesting that the studies that have looked at quality of life scale actually show discrepancy between what the teenagers feel and the parents report, because it's really the level of adjustment is different. So there's different things that we propose. We propose activities with other teenagers diagnosed also with MS. We propose also to parents who talk to other parents. One thing we do on a yearly basis is we have a family day. That's usually in September or October. So families can network, the kids can meet and can have some discussions, sometimes including actually the siblings, because it's already hard for the patient, but it can be also hard on the brothers and sisters. We need to make sure also they continue to cope with school and work for school, because sometimes in the wake of being shocked and anxious at the diagnosis, sometimes there's issues arising with school. But we know that issues with school can also arise relating to cognitive problems that can be seen with MS. And so what's been interesting is that with all the studies that have been done on pediatric MS over the past decade, it's really suggesting that in terms of the motor deficits or the physical deficits, they tend to recover very well after the relapses for most patients, on average better than in adults. However, there seems to be some cognitive impact of the disease that is detected in some cases earlier than adults, because as you were saying, children are expected to be in school every day and function at a very high level, and they have to develop new skills, memorize lots of things, and even small cognitive changes can actually have a big impact in the result in school. So we try to detect that early. We work with a social worker to identify psychosocial issues. And we work also with a neuropsychologist to actually have baseline evaluations for these patients and then follow-up evaluation 2 or 3 years later. So we monitor how well they are doing in terms of the anticipated normal cognitive and psychosocial development.
As you were talking earlier about 4 and 5-year-olds being diagnosed with MS, it was very clear that MS doesn't respect age limits, and it's a topic that we need to hear so much more about. So, Dr. Waubant, thank you so much for joining us today, and thank you especially for leading the fight against MS on behalf of all the children who continue to benefit from the work that you do. Thank you.
Thank you for the kind words.
Well, that's going to wrap up this week's episode of Real Talk MS. You know, I appreciate all of you who listen every week, who download the podcast episodes, who subscribe to the podcast, and who've gone on social media to tell your friends about it as well. As a result of all of your efforts, even though our podcast is just 6 months old, we're already in the top 20% of all podcast downloads in the world. So thank you for that. If you have an extra moment while you're listening, head over to realtalkms.com/rating, RATING, and do me a favor, leave a rating and review of the podcast for Apple iTunes. And by the way, if for any reason you're not finding this to be worthy of a 5-star review, I'd love it if you sent me some email with some suggestions about what else we could be doing or how else we could be doing it. You can reach me at John, that's Jon, at realtalkms.com. My name is John Strum. Thanks for listening, and we'll catch you next time.